Brad and I have a unique episode today, as we're very lucky to have Dr. John Partridge with us, who is an emerge doctor at Oakville Trafalgar Memorial Hospital. Welcome, John.
Thanks,
Dr.
guys.
Partridge, I should say.
Thank you for having me.
There's a lot of information out there. Mainstream media, of course, kind of focused on getting people to follow the rules. There's great podcasts I've listened to with infectious disease doctors who are very good at breaking down the science. With Dr. Partridge today, I really think we can provide listeners with some exceptional insight by bridging the gap between the data we have and some of the projections being thrown around, and the impact on the real world in the short, medium, and long term. Most of our listeners are entrepreneurs and business leaders who are thirsting for information so they can plan the best way possible. Obviously, we're going to dive into this stuff, but John, can you just start by telling us a bit about yourself and your career as an ER doctor?
Sure. Once again, guys, thanks for having me. I've been practicing emergency medicine for the better part of about 15 years now. Like all doctors, I started my medical training after undergrad university. So I spent 4 years at the University of Toronto Medical School and graduated from there. And then in Canada, actually, there's two streams of training to basically be a full-time emergency physician. One is through a family medicine stream where you do 2 years of family medicine and then a year of emergency medicine training. And the other is what's called a Royal College training program that is 4 or 5 years in duration. I did the former. And so I went to the University of Western Ontario to complete residency. And being from the West End of GTA, growing up in Oakville, my wife and I decided to move back here, and I started practicing primarily in Oakville in 2007. And I worked at a few other departments, but I've basically only worked in Oakville for the last 10 years or so. And so I've been there for a while. And seen a lot of things. When I was a medical student, I did go through the SARS period in Toronto when I was a medical student there. But this is a whole other kettle of fish that we're going through here. Very crazy time in medicine. So that's sort of my story.
Yeah, it seems like we're kind of getting closer to the eye of the COVID-19 storm here. Can you give us a brief synopsis of what we're dealing with in COVID-19 and kind of how we got to where we are right now?
Yeah, I mean, this new novel coronavirus, we were starting to hear word about it, through the media mostly in December 2019. Unless you've been living under a rock, you sort of know the story that this virus was born out of an area in China, thought to initially be the result of some exposure to a sort of a food market. And then it was fairly apparent that this was actually spreading between humans. And really, it seemed to be very confined to China. And, in Canada, we didn't even really think much of it until, I would say, we started hearing little bits and pieces about it in January. Ever since SARS, really, emergency departments do screening in triage when patients come in and ask about travel history. And whenever there's a new virus brewing somewhere in the world that has the potential to have epidemic or pandemic components to it, they usually ask about those specific areas. So, for instance, in 2015, there was the Middle Eastern respiratory syndrome that was coming out of the Middle East. And so for a period of time, we would ask people at triage, had they traveled to those areas? And if they had, then they would be immediately isolated and, consideration would be put as to whether or not we needed to test for them. So starting in about mid-January, we started asking about, had you, recently come from the Hubei province in China? And then that sort of expanded to, all of mainland China. And then as things started progressing sort of into sort of late January, February into Italy and other places, we started, Korea started asking about those. But, it really was, it felt like it was really more a formality. Most of these patients that we would see wouldn't really qualify for testing, or, if they did, there wasn't, there was sort of instructions to sort of isolate at home until the test results were come back, and they would come back quite quickly because, there was very few tests being done. And then really, I would say at the very beginning of March, that's when things really started picking up. And, especially in Oakville, we started having meetings about planning and precautions and the need to be a bit more aware and careful about these things. And then things fairly, quickly exploded. And I would say by about the end of the first week of March, we were sort of in full planning mode. There was sort of new communications coming out every day about whether, whether we should be traveling, what the ramifications were if you were to travel. And, since about the last week of March, it's been exactly what you're seeing in the media, is where all we do and all we think about is around this virus and attentions to contain it. We are, we've closed down all of our elective surgeries. All the clinics in the hospital have closed down. We've seen a huge decrease in the number of actual emergency visits that are not related to, respiratory illness. It's everything and anything we do right now. So it's been an experience that I'm sure as a physician I won't experience again in my lifetime.
Yeah, I was going to ask you about the experience at Oakville Hospital right now, but you kind of touched upon that. So I want to ask you about SARS. And you said that when you first came in, you were here during the SARS, epidemic. It was an epidemic,
but it was much more limited to certain places, and Toronto was one of the big centers for sure.
Yeah, and do you feel that had a big impact? And you mentioned that actually changed policy on the triage. Do you feel that really helped you as a medical professional in being able to deal with COVID-19? Well,
it did and it didn't. I mean, it certainly it made everybody very aware of the potential for something like this. Truthfully, SARS, while SARS is a very similar virus. It was also a type of coronavirus, and they are now dubbing this COVID-19 SARS-2 essentially, because it is very similar in structure, but it is different in many ways in that SARS was, especially in Canada, was a hospital problem. It was an illness that was really transmitted amongst hospital patients and healthcare workers. The rest of the community was fairly exempt. And so while you still saw the same type of lockdown procedures that are going on in the hospital, and that's helped, I think, with policy in the hospital, it didn't have the same effect on the community. I mean, we weren't shutting down the entire world because community spread wasn't really as much of a thing. So in that sense, it's helped from sort of planning within the hospital, but I don't know that it had that much help with planning everything else that, the ministries and whatnot have had to deal with.
Dr. Partridge, is a huge mask debate right now, it seems. Dr. Tam seems to be towing the line that healthy people, sorry, I shouldn't phrase it that way. I'm not really sure what the answer is. Towing the line that healthy people don't require them. But at the same time, we don't really know who's healthy or not. We also know hospitals should be the first priority for the N95 masks. Is it a poor form for people to be wearing them out in public right now? What are there other options? Could people be doing their homemade masks? And what is the supply like at the hospitals for masks right now?
Right. I mean, I think in order to understand the mask issue, and quite frankly, I don't know that we have all the information scientifically to be able to 100% tell people what to do. But to understand the mask issue, you have to sort of understand how this virus is transmitted, or at least thought to be transmitted. And so there's different ways that infections are transmitted, right? There's, airborne, where something like chickenpox, but this or contact, where you're sort of just, you're only going to get it if from touching. But, this illness seems to be what we call a droplet contact exposure, meaning the virus lives in respiratory secretions. And so if somebody coughs or sneezes, then that they sort of expectorate those secretions, and they live in these droplets, but then they quickly fall to the ground. So they're not sort of aerosolizing and floating around in the atmosphere for any long period of time. And, the thought is this whole sort of, 2 meters or 6 feet social distancing comes from the fact that the thought is that these droplets are probably not going to be able to carry more than about 6 feet before they sort of fall to the ground. But the other issue is that when they do fall to the ground, or whatever surface they fall onto, they don't just die immediately. They can sort of still live on those surfaces. And so if you then go and touch these surfaces, and then, put your hands near your eyes or any other mucous membranes, your face, then you can get it. So the purpose of the masks is to prevent that very close contact of droplets getting towards you. And then the other part of it is the masks themselves will prevent those droplets from actually being pushed in. If you are affected by the virus and you've got this mask on and you're coughing and sneezing, then having a mask is going to decrease the amount of droplets going into the atmosphere, into the community, and protect others around you. So for people wearing the masks, they're probably protecting others more than they're protecting themselves. And so, and then there's this other issue of, can you be spreading this virus before you develop any symptoms? And that, again, there's some thought that there probably is a little bit of that going on. To which degree is very difficult to quantify. So if you look strictly at what the recommendations of, say, the CDC or the WHO are, they are saying that, if you're not a healthcare provider, then you really don't need to wear a mask. Now, is that because that's the science and that's what the science says, or is that because they are cognizant of the fact that if the community all starts using up all the masks, there's not going to be any left for us? And I don't know the answer to that. I suspect that the answer is somewhere in between. Do I think that everybody out there needs to wear masks right now? If we're all social distancing like we should be, and we're staying sort of 2 meters or 6 feet apart, then based on the science alone that we know, then probably we don't need to. The other issue that they come up with masks is that, when you do have a mask, and I can attest this because I have to wear a mask the entire time I'm working now, you do want to adjust it from time to time. So even though you're supposed to not be putting your hands near your face, you probably are more so when you're wearing a mask. And then the N95 piece is the most contentious among healthcare workers, because N95 really is meant to be for airborne illness. If this is truly a droplet illness, then an N95 is deemed to be not necessary. The trick is, if somebody coughs aggressively near you and puts these particles in the atmosphere up to, and you're in very close contact with someone, then a regular surgical mask may not be enough. And so a lot of healthcare workers are very worried that we're being provided with just really surgical masks, and the N95s are being conserved for times where there is a very high degree of forceful aerosolization of these droplets. Things like, when you have to put an endotracheal tube into somebody's lungs to put them on a ventilator, procedures like that are high risk. So they're saving those for those procedures. But there is a lot of debate about whether or not we shouldn't be employing these more. And then again, the supply chain becomes an issue. And are we being told that we are only to use N95 for high risk procedures because that's what the science says, or is it because it's a supply issue? And I don't know the answer to that, but it does create a lot of anxiety amongst healthcare workers.
I imagine.
Yeah, for our listeners, we're recording this on April 1st, 2020. This will be kind of relevant to the next question. What are you bracing for in the coming weeks?
Yeah, so I mean, we really are preparing for the worst and hoping for the best, I would say, is the best way I can say, is that, you know, if you look at, you know, the trajectory of some other countries, things were fairly quiet for a period of time and then exploded. And every country is different, and the testing, the degree of testing and the degree of social distancing is different. So it's hard to know where we stand right now. I mean, on April 1st, we just had the most recent release of data, and in Ontario, we've had the biggest jump in cases that we've seen. You know, we've been sort of, last couple of weeks, it's been sort of, 50 cases and then 100 cases. And then the last couple of days, it's been 200 cases. And now we've jumped up to 400 new cases. Now, some of that is, I can tell you, because there's been a backlog of testing. I know personally, I manage our schedule in Oakville. And so I have to, there has been some physicians who have undergone testing. And of course, while they're waiting for their test results to come back, they have to be off the schedule. So I'm acutely aware of who's been tested and how long they've been waiting. And believe it or not, we've had physicians waiting more than a week to get their results back. And so they've been sort of sitting at home waiting for the most part, feeling fine. And so I know that there's a big backlog of testing. And so they're doing their best to improve that. There's more testing capacity that's coming. I know that our hospital is now doing their own testing. It's been sort of just started. So that's going to take some burden, and other hospitals are doing the same. So it's not just the ministry labs that are doing these things anymore, but what these numbers really mean when there's such a backlog of tests coming out, it's hard to say, but it's not reassuring when the numbers keep going up, even if you want to try to rationalize them that we're testing more and we're decreasing the number of testing. When you look at sort of centers like, Italy and Spain right now that are just completely overwhelmed, you worry that that's what's going to happen. I'm thankful to say that while we have seen our fair share of cases in Oakville, and we do have some sick patients in our ICU with this disease, we haven't seen the rush of patients yet. We're seeing a significant decrease in our volumes. So people are staying away as they're instructed and not coming to the emergency department for non-emergent reasons, which, on a day-to-day basis outside of this pandemic, we would see a lot of. And so that's helping. It's allowing our hospital to discharge lots of patients without admitting a whole bunch more. So we've got lots of open beds in anticipation of a surge. Whether we're going to see this surge, it remains to be seen. I think this upcoming week is going to be the real telltale sign as to whether all these social distancing measures and precautions are actually going to bear out. But it's possible that we get this massive surge and we do get a bit overwhelmed. So we are bracing for badness, but kind of in the back of our minds, hoping that all this effort that the community has put forward is actually going to bear fruit.
Yeah, I want to circle back. You mentioned that the doctor, one of your physicians has been out for a week just waiting for their test results. What is the typical turnaround on that? And how do you work the testing of the doctors if they're going to be off for that long?
Yeah, so the test itself really should be able to be turned around within a day. If there was not a capacity issue to run these testing, meaning if they had all the resources in the world to do the test, these swabs should be done in a day. And that's kind of what we were seeing at the very start of this, when we were just testing, a smattering of patients over the course of a week, sort of in February. But as the number of tests came in, it was clear that, the labs that were running the tests, that were authorized to run the test, didn't have the capacity. And so, hundreds of thousands of tests were just sitting on the back burner waiting. And you would think, getting the physician force back onto the front lines would be of utmost importance, but it doesn't appear as though that was the case. Now that our hospital is doing the testing, of course, they're going to prioritize healthcare workers so that if they are able to, they can get back to work. Managing physicians who have to miss because of that can be a challenge. As I say, we are fortunate in the fact that volumes have been exquisitely low. And so our need for our usual complement of physicians hasn't been there. And so pulling somebody off the schedule for a week hasn't been an issue thus far. But you can anticipate that if we do get the surge, and invariably some physicians are probably going to be exposed, or at least need to be tested again, then it may become an issue. There is capacity to help with that, in that there are many physicians, especially specialists, who much like the rest of the world, have basically shut down their business because a lot of their practice is deemed to be elective. And so if need be, some of these specialist physicians can be redeployed in things like ICUs or emergency departments. Hopefully it doesn't get to that, but that is one of the contingency plans.
So how do they actually test for COVID-19?
So it's, there's a few different ways, but basically the gold standard that, everybody is seeing in the news is a nasopharyngeal swab, which essentially is a very thin Q-tip that gets jammed into the back, through your nose into the back of your throat to collect secretions. And that is basically tested by it's a complicated laboratory test called PCR, where they're basically magnifying the DNA from that so that they can identify the specific DNA of that virus. And so that's how they basically test it. It's not perfect, but it's about, they talk about sort of an 80% accuracy, which, in somebody who has, you're very concerned about, and you get a negative test, there is always an opportunity to repeat it. There seems to be a bunch of novel, quicker tests that are coming down the line that use different methods that have to be sort of held up against, what is considered the gold standard of the swab. That, when you talk about these 5-minute tests that are sort of trying to be fast-tracked in the US by the FDA, those are different type of testing, but maybe incredibly valuable in that you can sort of have a result within sort of 10-15 minutes, can really affect the way you're going to manage somebody for sure.
John, I'm going to switch gears for a second. We've seen a lot of conflicting reports, like even amongst scientists, around how deadly the virus is. I think it mainly has to do with the denominator, given we don't know how many people are actually affected, and speaking of all these the testing and the results and the timing of it. So I've heard as low as 0.7%. I've heard as high as say 2%, higher, but I think that number has come down recently. Do you have an opinion? And then what are some of the factors that maybe swing that number? Because certainly country to country, that number varies a lot. On the successful side, you've got Germany at only 0.5%, and personally, I find that a little bit puzzling. I mean, it's great for them, but tragically in other countries, it's such as Spain, and even Italy is much higher.
Yeah, I think you're right. I think part of it has to do with we don't really know how many people out there really have this virus. There's a large portion of people who have very mild illness that never get tested. I mean, I can speak to our situation in Canada where, the testing, the target audience, if you will, who we're going to test, had changed quite dramatically over the course of the first month that we were dealing with. Initially, we're testing only people who had returned from the Hubei province within the 14-day window. And then, we expanded the testing to those who had symptoms, who had traveled from, a handful of countries, Iran, Italy, Korea. And then and then we changed to testing everybody who had traveled. And then the travel piece got completely pulled away. And so now we're testing, only high risk population. So even if, a young person comes into our emergency department who's otherwise healthy and has symptoms that are convincing for COVID, we say, yeah, you probably have it. Go home, isolate yourself for 14 days. Or if, you're still having symptoms past 14 days, you have to isolate yourself until you're, don't have any symptoms for 24 hours. And they never get tested. So those patients don't even end up on the radar. So, the more testing you do, your mortality number is probably going to look better because you're picking up all of these very mild disease, people that, do well. And so I think testing has a lot to do with it. I think Germany looks really good for a couple of reasons. Number one, they've done a lot of testing. Per capita, they've done some of the most testing around. The other thing about Germany that people don't know about is that their hospital capacity is, quite frankly, incredible. They have a huge number of hospitals, a vast number of ventilators, and so they are able to sort of treat everybody who comes in, whereas, some countries that have worse capacity, and, it's been talked about a lot in the media where, certain jurisdictions like Northern Italy have had to literally refuse to put certain people on ventilators because, they need to reserve them for people who have a better chance. The other issue is that some of those numbers may change as time goes on because even putting people on ventilators, the outcomes are pretty poor. I think I saw some statistics the other day that, 50% of people who even end up on ventilators, and they could end up on a ventilator for a week or two, still end up, passing away. Wow. And so there may be that there's a lot of people on ventilators in Germany and they're sort of keeping them going, but, eventually their numbers may increase. But I think you're right that the biggest piece is almost certainly just how much you're testing, how many people you're picking up. I think if you really want to know what the active disease burden is in a community, you look at two things. You look at number of deaths and you look at ICU admissions or how many people are on ventilators. And that will give you a better idea of what that disease burden in that area is. I think while testing has an incredibly important role in this, as far as sort of holding up the number of cases you have as to how well you're doing might not be the best indicator of where things really sit.
So just because I want to move it to some success stories, that's a pretty heavy one we just did. South Korea, Taiwan, Hong Kong have been really successful at flattening the curve. What have they been doing differently since we're talking about countries and different approaches?
I mean, I think it's testing. I mean, the more testing you can do, the more cases you can identify and then isolate, the better you're going to do. So, we saw, how aggressive South Korea was with testing from the get-go, right? They were doing, tens of thousands of tests a day and doing it in a very organized manner and really testing anybody and everybody who had any sort of suspicion. And, I think everyone can agree that if you have COVID-19 versus, if you're not sure, if you think maybe you've got the sniffles and maybe just have a cold, your threshold for being careful and isolating yourself is going to be much higher if you've got a positive test. And so, for whatever reason, their capacity was excellent from the get-go. Our capacity hasn't been as good, and while we're not doing terribly, I mean, if you hold up the number of tests we're doing per population up to some of the other countries, we're doing rather well. And I think the message is being heard and we're trying to escalate and increase our capacity. But the most important thing is testing. Because if you can identify cases and isolate them, then you're going to be able to snuff this out much quicker. And Korea continues to test aggressively, and their case burden is significantly decreased, and they're actually starting to reopen that country and starting to get on with life, right? Because they did such a good job of doing it. Now, sometimes you get a little, sometimes it's too late, too little, too late, right? So. These are the types of things where if you really institute something early like this and get on top of it, then you can snuff it out. But, as we all seen, these viruses, they grow exponentially. And every day that you're complacent, you're getting yourself behind. So, I mean, the USA.
Do you know why, John, the Korea, Dr. Partridge, they had the capacity to test so well? They were set up to do it so quickly. They had drive-through testing, I saw. Is there a different method that they use other than the swab?
No, it was the exact same thing. But it's just, for whatever reason, they had the resources to do it. I don't know the ins and outs of why, but we, in Canada just weren't set up. We didn't have enough swabs. You need a lot of chemical reagents to do these tests on these swabs, and we just didn't have the resources from the get-go to do it. And that's why we've had to be selective on who we've tested. I mean, if we could test every single person that came in, I think that there is some value there. The argument is, well, these young people, it's not that important that we know that they have it from a individual perspective, because they're likely going to do fine. Tell them that they probably have it, send them home. But when we're not sort of when there's no checks and balances to see what these people are doing after you give them instructions, I think it's hard. And it's a guess to say that if they'd have a positive result that they're going to be more compliant with recommendations. But I think common sense would say they do. Singapore is another country that's been very aggressive testing, and they've really seen very few cases and very few deaths. Testing, I think, for the countries that have been successful, it's been the testing that's really they can hold on.
So, Dr. Partridge, I'd like to play a bit of a game with you then. We're talking about the testing as a strong measure. We can do it overrated, underrated here, where overrated, the measure doesn't help as much as we maybe think. Underrated is that the measure might be more effective than people think, but maybe perhaps we don't have the right resources, and perhaps testing would fit exactly into that underrated category. Would you say that off the bat?
Sure, yeah.
Okay.
Yeah.
Great. So let's talk about some other ones. So closing of schools, would you say it's overrated or underrated?
Well, so, I mean, closing of schools is one piece of, social distancing, right? So if you were to put that in isolation of everything else, so if you were to close schools, or let's put it the other way, if you were to leave schools open, but then require everybody else to sort of continue on with their social distancing, you might get away with it because, again, you're dealing with a low risk population. Children, affected by this are not going to get sick, but they're basically vectors, right? So they're going to be passing that off to potentially other family members and whatnot. So if you, in some sort of bizarro world, could send your kids to school and then isolate them from everything else, then that would probably be okay. But I think it's hard to make a judgment on that in isolation, but it could work. But I think, it would be fraught with error.
Mm-hmm. Okay. So what about masks? We've already.
Yeah, I think masks, I would say, is, overrated for the general population. That would be the one that, while again, like you look at certain countries, you look at Korea and they're all wearing masks, but is that what's actually helped them? I don't think that's probably what's helped them. I think, the other measures that they've put in place has probably been more beneficial. if we are, again, it's one of these things, it's hard to judge this in isolation, but if we're all performing this social isolation correctly, then the mask issue, because this is a droplet disease that really shouldn't be, airborne and aerosolized in the community, then wearing a mask is probably not necessary. So I would definitely say that one would be overrated.
Okay. So what about healthcare capacity? We see in the, when we talk about flattening the curve, there's the straight line, which is healthcare capacity, and we want to push that line as high as possible and support it every way we can.
I think healthcare capacity, in the grand scheme of things, honestly, and obviously I'm a part of this, is probably not as important as all the other measures. I mean, obviously, if you can't care for these patients, you're in trouble. But really, that's the kind of like the healthcare capacity is the last sort of it's the last thing that you have, right? So, I mean, if you can do everything else well, then your healthcare capacity might not be needed. And so I would actually, if I were to pick one or the other, I would say that healthcare capacity is probably overrated. I mean, obviously we're doing everything we can to have as much capacity as possible in the event that these other measures are not working, but it's really the last, the last barrier of defense here.
So you touched on it with the schools, but physical and social distancing.
Yeah, I mean, I think at least initially, right? And we'll probably touch on more about, this is a very, challenging philosophical issue because but if you're just to look at the medical side of things, the way to stop transmission, I mean, because if you don't have contact, you're not going to transmit this virus. So, clearly that's been the message from, international bodies, national bodies, provincial, municipal, that has to be huge, right? So, it is at this time, it is probably the most important thing. So, underrated for sure.
Mm-hmm. So, travel bans, I want to break it into two parts, being stopping the movement. You see Premier Ford going as far to say, like, don't even go from Toronto to your cottage. You want to keep everyone, what they're trying to do is keep everyone localized so that we can help people from a local perspective and not have them moving around. So really it's two parts. We'll start with the local, and then we'll talk about sort of actually confining in planes and trains and things like that.
Well, I think the movement of people is more important to the people where you're moving to. So, I mean, I think, again, if you're practicing social distancing correctly, then, whether you're, if you travel, in a car to another location and you continue to practice social distancing, then it probably shouldn't be much of an issue. But having said that, there's a reason why we're not, letting people, there was travel bans initially instituted from areas where there was a lot of disease because, it would be better to have those, whether they're practicing social distancing or isolation or not, having those people in your local community who potentially could be affected is going to put things at higher risk. So, it's somewhere in between, but, I would say that going from, if you're practicing proper social distancing and you're going from Toronto to Muskoka, and you're continuing to do that the risk is probably pretty low. But I'm sure the people from Muskoka don't appreciate people from Toronto coming into their locale, given that Toronto is a hotter spot than Muskoka is. But overall, I'd probably say it probably doesn't help as much as you would think.
Mm-hmm. And what about the travel itself? So actually people, social distancing on a plane seems
impossible. Right. So, I mean, I think that, I would say to that 100%. I mean, air travel, or any sort of communal travel, be it a train or a bus or anything like that, it's part of social distancing. So, you cannot do that. So I think limiting people from planes is one and the same with social distancing. So I would definitely say that is an underrated measure that we're taking.
Yeah. To that end, do you think that the calls for Canadians to come home or everyone to go to their home country. We started that a couple weeks ago. I almost feel like everyone should have just stayed put.
Yeah, I mean, I think I wonder if I agree. I think ultimately, if you're saying that you don't want to import disease, then yeah, you should probably keep everyone here. I wonder if that was not more of just a way to reach out to Canadians to get them home as quickly as possible before more people got sick. But I agree that it probably wasn't a helpful tactic as far as the overall disease burden in our communities, but it was probably more of a way just to reach out to Canadians to get them back before things got too bad.
Okay, so what about the closing of non-essential businesses?
Yeah, I mean, again, that one is there's so many layers to that. But if you were to look at it just from a epidemiological control, it's part of social distancing as well. So I mean, you can't sort of half do these measures. And so things like especially businesses where you've got probably a reasonable amount of high risk people and the potential to create a lot of disease burden. It's not quite the same. I mean, it's one and the same of closing schools. As I say, with closing schools, you're dealing with a lower risk population. Businesses, you're dealing with a high risk population. So I think that is an integral part of social
Yeah,
distancing.
I mean, risk itself, right? I kind of feel the list is so long of essential businesses, it's almost comical.
Yeah.
Marijuana stores went from being illegal to being an essential business in the matter of months. Is it almost the list is not basically low risk businesses are allowed to stay open? Is that almost a better way of?
Yeah, I don't know. I mean, you're right. It's very interesting to what they consider an essential business. I mean, even just speaking from a medical perspective, doctors' offices are closed. They are considered, you never think you'd hear, on one hand, when we negotiate with the government, we're not allowed as a group of physicians to strike because we're considered an essential service. But then when this comes along, half of us are deemed non-essential. So, it's fairly arbitrary. I think they're doing the best they can. Far be it for me as a physician to determine what's essential and non-essential, but it does, there is a few head scratchers in there for sure.
I think a great deal of the population is now a little worried about the unintended consequences of all the steps that we've taken. A poor economy negatively affects the health of society in a lot of ways, not to mention what isolation does for people from a mental health perspective. Can you speak to the balance, I guess, we eventually have to face, and what's the stress on the healthcare system at this time?
Yeah, it's a philosophical answer that I think really will only be able to answer in retrospect. There is school of thought, and Donald Trump is one of the people who says, almost to the degree of let's just reopen the country, isolate the high risk individuals, let the young people sort of pass this around, develop herd immunity, and there's going to be some collateral damage and some young people losing their lives, quite frankly. But life goes on, and we can get back to things sooner than later. The problem is we don't really know what the disease burden on young people would really be if we just sort of let this go run rampant. And certainly there's lots of reports of very healthy young people on ventilators, losing their lives. And so it's a very big challenge. I mean, there is no doubt going to be, especially the longer this goes on, there's going to be ramifications through all walks of life. I can speak specifically in medicine. We're seeing, health visits decrease exponentially, and there's got to be some consequence to that. I mean, in the emergency department, we're seeing almost exclusively, COVID-related concerns. And so, like, what happened to the appendicitis or the heart attacks or the heart failures that I would routinely see in the department? They can't have just gone away. And so presumably these patients are at home and getting sicker. And so one concern I have for sure is that, some of these patients who would have presented much earlier in their disease course are going to come in much later and be much sicker. And that in itself is going to be a burden on our hospital beds. Obviously the long-term economic fallout is inevitable. And, again, I can speak to medicine, it's not just businesses that are being affected. I've got many friends in the medical profession who are essentially not doing any work right now, not earning any income. And so there's a trickle-down effect everywhere. We've started on this path of social isolation and trying to mitigate this disease. So I think we have to see it through for a while. You can't sort of abandon it now, just as the positive effects are hopefully going to be borne out. But long-term, how long can we really do this? And how long are people going to listen? I think those are really important questions. It's nothing that you can fit into a medical model. Where the answer lies is going to be very challenging.
Yeah. Do you think this is going to revolutionize the medical field as well? Because I know that, even our kids, our family physician did a telephone call with us and then had to call the prescription in to the pharmacist. So that all got done by saving us a trip going to the office.
Yeah, I think telemedicine was already coming. There was certainly, provincially funded programs to allow for some telemedicine. It was more around people who had poor capacity to get to doctors' offices. Now that this has occurred, the government has put in, billing codes where physicians can actually bill OHIP for these interactions, and they probably aren't going to go away. I think it is going to change things to some degree. And it makes sense. There's a lot of times where you would seek out medical care where a physical exam is not necessarily needed. And I think it is certainly going to change things. I think the long-term effects of this virus are not going to, in medicine at least, are not going to be just while the active pandemic is ongoing. Like, I'm going to be wearing PPE probably for the next half year or year, I imagine, during my shifts, because this is probably not going to go away until we have a vaccine. And even then there's going to be cases out there. So it's going to, this is definitely going to change the way we practice in the very short term, but I suspect long term, there's going to be lots of new things that are born out of this for sure.
Yeah, definitely want to ask about the vaccine, but I want to come back to, you mentioned some models, and there's a site of the U.S. and obviously the U.S. is a little more dire than Canada, or so we've been hearing. It's from the Institute of Medical Health Metrics and Evaluations. So for anyone who wants to Google that one, it's pretty easy to find. I actually had to change my numbers as of an hour before doing this podcast. As of yesterday, they were projecting a peak of 220,000 hospital beds. So that's not ICU beds, but hospital beds on April 25th. And today, just an hour ago, it was 260,000 beds needed on April 16th. So it can also show the healthcare capacities as you drill down by state, and you really see what the challenges that New York is facing. I haven't seen similar data here in Canada. Do you have anything you can share, or what kind of a peak are you expecting, and what do you think the level will be in our ability to accommodate?
It's challenging because, again, with the US, testing hasn't been great, right? I mean, most suspect that coronavirus was being spread in the community in a lot of regions of the U.S. far before they even were thinking about it. And so when they finally got going with the testing, the cases exploded. And as we've seen in other areas of the world, it does seem to really cluster in certain areas. And and it just goes to show you what exponential growth can do. So if you don't control this from the outset, it just takes off. And so in Canada, again, it's very challenging to predict. And that's why we're kind of sitting on eggshells here, wondering if we're going to see this explosion, because we don't have a good grasp on what is really going on in our communities. We know these positive test results, but we also know that we're not testing everybody. And so, what I can say from a personal experience in Oakville is that we haven't seen the surge yet. We've had a few periods where it kind of looked like something was maybe coming, and then it kind of died down again. So I wouldn't anticipate we're going to ever get to the point where the U.S. is. It's just, as a country, we just have such a more distant population as far as, how dense our population is. I mean, Toronto certainly would be the one concern, as being a very large city. And so I would worry about cases clustering in an area of Toronto. I'm hopeful in Oakville that's got a little less dense population, that we're not going to get to something like that. But I can't imagine that we're going to be in a crisis like Italy or New York City.
Mm-hmm. Yeah. Do you, Dr. Partridge, do you feel we're equipped for the demands on healthcare that we may see in the coming weeks?
I think it's variable from sort of municipality to municipality. I'm fairly confident. In Oakville, we're very fortunate that we just built a brand new hospital. It has already some extra capacity built into it that isn't being used right now to accommodate future population growth. We're fortunate in that we have a lot of private donors, but I don't think we're completely exempt. We're certainly trying to conserve PPE. So while I don't have the numbers and I don't know the inside track about what our actual PPE supply is, I do know that there is efforts to conserve it before the storm, if it does hits. So I mean, I think there is definitely, over the last month, there has been efforts to improve capacity. We've been working very diligently to try to decant patients that have been tying up beds that probably could be cared for in an alternate level care facility. They've been coming up with creative ways to get patients out of hospitals into long-term care or other type of care situations. And so the assurances I've been given by the executive of our hospital is that we are going to have the capacity even in the worst case scenario. Other hospitals, I can't speak for them. There's obviously concerns. There are many hospitals that are actively soliciting PPE. Just today, Joseph Brant Hospital just down the street in Burlington announced that they are building a temporary space to house their potential COVID patients. So wow. There is planning going on, and so capacity is definitely a concern. We've seen it around the world where they run out, and it's just a disaster. So I think everyone's doing their best. As I say, well, it remains to be seen. I think it's so challenging when you're not testing aggressively as you could be, or you really don't know what you're dealing with as to where things are going to go. When the numbers keep going up, though, it does give you pause and makes you a bit nervous for sure.
Yeah, the new graphs, I mean, originally when we saw, graphs of what this would look like, it was a perfect bell curve. But in reality, we kind of ramp up to a peak quickly, and then it's kind of a drawn out backside, I guess you could say, to the graph where there's more, it takes longer to get the patient count down. Can you speak to sort of what we're expecting, what we can expect during that time? I mean, a lot of us want to know, I mean, certainly we're concerned about the medical community. You talked a bit about your capacity, but how can our daily lives and how we can maybe wean off some of the measures?
Yeah, I think it really comes down to seeing the other side of that curve. So once you start seeing, we don't, and this was talked about in the press conferences today by Dr. Tam, is you don't know when you're on the other side of the curve until you're on the other side. And so, it could very well be tomorrow that we've got less cases, or it could be that we've got double the cases. And so that's the difficult thing. So, they're projecting weeks more of this type of behavior. Nobody's willing to commit on when this is going to end, because quite frankly, nobody knows until it's under control when it's under control, I guess is the way to say about it, which is a very challenging thing for everybody to hear. But it's just not predictable when you don't have all the data. And when we're not testing everybody, we don't know who and who doesn't have it, and who's going to come out of the woodwork with symptoms 5 days, 10 days from now. So it's very challenging.
Yeah, people talk about the virus slowing down with warmer weather. I don't know if there's any truth to this, but if so, there's also the mention of a second wave coming back in the fall. Can you comment on that?
Yeah, I don't know that the weather is going to be an issue. We're seeing this illness in all parts of the world, right? So whether the warm weather mitigates it, it's hard to say. I think that we're invariably there will almost certainly be another uptick at some point in time. We'll get it under control, and then it will start coming back. I think even in places that have done an excellent job have seen things like that. Singapore is a good example. It looked like they had almost completely snuffed it out, and then they had to ramp up their social distancing measures and testing again. I think this is until we have either a great treatment or a vaccine, we're probably going to be dealing with this in some capacity.
So speaking of which, what's your take, I guess, on the vaccine? I hear 18 months away. The optimist in me wants to think, given our tremendous innovation that the world has experienced, how can it possibly take 18 months? We hear that it has to do with the research and the testing, I guess, of it. What do you think? Are you buying or selling 18 months?
Yeah, I mean, I think that would be the standard answer for any vaccine. I mean, vaccines take a long time to prove their worth, because you need to show that immunity is possible, and that you can't say someone's immune to something after a month, right? You have to see it through. And so even in the most optimistic scenarios, I mean, I guess the flu vaccine would be one where they are able to turn over a vaccine every year. But the difference with this is that you're starting from scratch, whereas with the flu vaccine, you're already sort of dealing with recurrent strains and just sort of tweaking it. This is a brand new virus that we've never seen, and that's what makes it so challenging. And so I think 18 months is maybe even optimistic, to be perfectly honest. Okay. Even with all the resources and capacities going into it, it'll take that long before they can prove that it's actually effective.
Okay, so let me grasp for some good news here. What about the medical treatments? Sounds like maybe there's more opportunities in medical treatments.
Well, I think there always will be. Again, the problem is the novelty, and there's just not enough. There hasn't been enough cases. I mean, to really prove something's worth in a clinical trial, you have to have very robust numbers. And so a lot of these treatments, we're looking at, a handful of cases, and a handful of controls. And so what might seem very promising in a very small study when that is extrapolated to a bigger study may not be as effective. So they're trying. I mean, I think a lot of these patients are very, very sick. So there's not a lot to lose, to be perfectly honest. But some of these therapies, I mean, the big one was the one that Trump was touting without very little sort of knowledge on it. Hydroxychloroquine or chloroquine. These drugs can be quite toxic. And so you have to be a little bit careful. And you have to let, I would say that all these treatments should really be just done on hospitalized patients. This business of, being prescribed one of these medications for mild illness that doesn't require hospitalizations by, say, like a family doctor is, fraught with downsides and major concerns. So, they'll see. They're looking. I don't think anything has been definitively effective right now, which is, the challenging thing with this illness is that really the treatment is largely supportive, and you'll get through it with your immune system or you won't.
Yeah. Now, in our house, the 2-second rule doesn't exist. It's more like a 30-second rule where the kids can eat whatever they want off the floor. Now, do we risk sterilizing our environment so much that we weaken our immune systems and allergies go through the roof? I know there's a book out there called Let Them Eat Dirt, which is about saving your child from an over-sanitized world. What's your opinion on that?
Well, I mean, I think, as we've all, and I don't pretend to be an infectious disease specialist, but, as we've all sort of experienced, when our kids first get into daycare or into, preschool, kindergarten, what have you, that they tend to get quite sick quite frequently. And then there does seem to be a plateauing of that where they seem to have acquired immunity against things. And some of it is because, there's seasonal viruses that, once you've been exposed to them one time, you're probably not going to get them again, or they're at least similar enough that your body is able to, develop some sort of immune response to it. So certainly by isolating completely, we're not being exposed to those other seasonal illnesses. And it's quite possible that when all this is said and done, that there'll be a larger burden of disease based on those other illnesses that, suddenly explode as well. I mean, influenza would be a prime example. I mean, influenza has a huge burden of disease now. It's much more prevalent. Most people also do well with influenza. Influenza is very rarely affects young people in a negative way, where this virus doesn't. But so, that would be a prime example where, when the dust settles with this, are we going to sort of then see a big influx, much like I talked about, seeing increased heart attacks, increased heart failure, increased acute surgery problems? Are we going to see an increase in demand on the medical system because of other viruses that weren't circulating because we were isolating?
So once somebody gets COVID-19 one time, are they immune?
So the thought is, the short answer is probably, but for how long is the answer. So there has been some case reports of people questionably getting COVID twice in a very short period of time, but it's not clear, how accurate that is. The thought is that, once you develop antibodies, you are going to be immune, but is that immunity going to last forever? And again, I sound like a broken record here, but because this is also new, it really remains to be seen. But the thought is certainly that, if you got COVID 2 weeks ago and recovered completely, you would probably carry some degree of complete immunity for, months at least. But whether that would last forever is the question.
Yeah. Okay. As a doctor and medical professional, what does life after COVID-19 look like to you?
Yeah, it's going to be different, I think. As I say, I'll probably be wearing these, masks and gowns and gloves for an extended period of time. I think, social distancing within the hospital is going to be a mainstay. There's going to be much more precautions around certain things. And, it's going to, I think it's going to affect in my outside life, it's going to affect me the same as everyone else. We're looking at cancellations of all sorts of kids programs, extracurricular activities, vacations likely. It's going to affect my, personal financial bottom line, much like everyone else. So, it's definitely going to be a sentinel event in our lives, no doubt.
So what about take us to a longer outlook, do a 2-year outlook? Do we eventually have to go back to some of our normal ways of operating, or are people going to be fearful, and even should they, based on the other discussion around that we frankly we can't over sterilize our environment as well.
Yeah. I mean, I think we're, much like, on a much smaller scale, but, eventually things will probably get back to normal. How long that's going to take, it's hard to say. I mean, with SARS, there was a lot of precautions that lasted for years that eventually, as with anything, once the threat seems to disappear, people become more complacent, and those restrictions come off. This isn't going to last forever, but until the next sort of thing comes along. Now, how frequently is this going to happen? It doesn't seem to happen that often where you get to something like this. I mean, they point to, the Spanish flu in 1918 as being the last time that there was something of this nature. So hopefully it will be the last time in our lifetimes. But I think, things probably will change. I think there's probably going to be more, social distancing practices, more hand washing, more concerns around transmission, not only on a individual level, but likely on a sort of, within municipalities, within businesses. I suspect it's going to change a lot of practices.
Yeah. So sort of to summarize a little bit, there's sort of a debate, I guess, and it's not the cure, but maybe the approach is worse than the disease. Do you or the broader medical community think we should be approaching it differently?
I think the vast majority of people are in agreement with what we're doing. I think there is definitely a contrarian view that it could have been approached differently. But it's more it's not thinking about the medical side of things and what is the sort of most reliable way to snuff something out like this. I think if you were to put it into isolation, how do we get rid of this as quickly as possible? Of course, you lock everybody down, you don't let anybody interact, and you test as many people as possible who have symptoms, and you further isolate those people. But pragmatically and practically, that can't work, right? I mean, society has to move on, or it's going to collapse. So there has to be some sort of middle ground. There's certainly, as I say, there has been infectious disease specialists who have said that, we're doing this wrong. The effects on the economy are too great. We should be, isolating the most at risk and, taking our chances with the less at risk, and allowing sort of some degree of business to resume. As I said before, I think we've gone down this road now. We've got to see it through a bit, at least until we're on the other side of it, before we can start pulling things away. I mean, it seems like every day we're putting on more and more restrictions. My hope is that these restrictions work and we get to the other side of it sooner than later. It's discouraging when you start hearing people talking about sort of middle of the summer before we start getting back to anything. And I think that's, largely just a prediction. But I think there is an argument to be made that there could have been a different way. I think that probably that ship has sailed. But then the next step is, okay, we've done this. When are we going to when can we and when is it reasonable to start lifting some of these restrictions and getting back to something similar to what we were doing before.
Yeah. Well, John, Dr. Partridge, thank you so much. I apologize for slipping John in there every now and then, but I have known you since we were 13 years old. So
it is my name, so that's okay.
Difficult for me to remember to call you doctor.
Correct.
But I really, we can't thank you enough for doing this and taking so much time. It really is some valuable information to hear from you firsthand. And I also want to say thank you to all the staff at the hospital and all the healthcare workers. Is everyone feeling the love that the community is pouring out to?
Yeah, certainly feeling a lot of support from the community. It's much appreciated. Sometimes I feel a little bit undeserved. We are, in my opinion, where I am doing my job. That's what I was signed up to do. But I do appreciate the support. It is a anxious time, no doubt about it. It's not the most enjoyable time to be going into the hospital every day, but as I say, just like everybody else, I'm just hoping and praying that we get through this on the other side quicker than they're anticipating, and hopefully we don't see the disasters that we're seeing in some other parts of the world. I'm optimistic, but at the same time, still being as cautious as possible.
Yeah.
Thanks so much, Dr. Partridge. Totally appreciate your time. Amazing discussion. Thanks a lot.
Okay.
Yeah, absolutely. It's public service. Thank you.